Hello again. Welcome to ENT Shorties, micro lessons for medical professionals wanting to learn practical approaches to ENT complaints. This case illustrates the lost 4 techniques discussed in the last video, and you will see these in future videos. Note how asking the why question is so critical. Let's just briefly review. 1. Ask. Patients will often not volunteer critical information. Number 2. Look beyond the specific area of complaint. Do not be led astray about what you've been told the problem is. Look at radiographic studies directly, not at the radiologist's report. 3. Touch. Don't be afraid of a good old-fashioned examination. Know the findings and how to interpret them. And 4. Think. Why did this happen? Be suspicious like a detective solving a mystery. Now, let's get to the case. A healthy 60-year-old active female from the emergency department was referred after a fall. She hit her head, temple, and orbital bone on a dresser, but no additional history was provided. Because she reported double vision, the emergency room physician ordered a head CT scan looking for orbital fractures or hematomas. The scan was negative, but she was referred to confirm this. So the first thing I did was ask more questions, especially why. I asked, why did she fall? It seemed to me that an otherwise healthy 60-year-old shouldn't have fallen. She emphasized she didn't trip, but her balance had been off recently. She denied changes in medications and stated she hadn't felt ill. I asked her, when did the imbalance begin? And she said it started when she lost hearing and had ringing in her right ear. She was wobbly most of the time. She had not volunteered this because no one had asked, and she didn't think it was relevant. It is a simple examination. I noticed she had disconjugate gaze, meaning her eyes didn't move in synchrony, especially when looking to the sides. The otoscopic examination showed no fluid or blood in the middle ear, but tuning fork tested indicated a right hearing loss. The 2 tuning fork tests, the Weber and the Rene, took only seconds, but suggested a sensory neural rather than conductive loss. Next, I looked at the head CT. I didn't just look at the report. There were no fractures, masses, hematoma, or inflammation of the orbit. The middle ear and mastoid were clear, and there was no temporal bone fracture. So I asked, why would she have diplopia? I suspected a possible neurologic problem in the brainstem. I looked more closely at the CT, specifically at the cerebellopontine angle, the CPA. CT isn't the best test for evaluating this area. MRI is, as everything on CT is usually uniformly gray. But now I saw a suggestion of something abnormal. I called the radiologist, who immediately agreed that there was likely a large mass. He said they didn't concentrate on this area previously, but now it seemed evident with context. An MRI confirmed an acoustic neuroma. She was referred to a neurotologist at a regional tertiary center. Asking questions and thinking about the whys led me to focus on the important areas. Simple examinations led to appropriate testing. Looking at the x-rays rather than relying on the report was invaluable. What would have gone wrong if we had not found this tumor? How many more falls or complications would have occurred? Today, the patient's doing well after surgery, and she's very appreciative. If this stimulated you to learn more, please see the other videos and share them with others. I encourage you to leave constructively positive or negative comments and tell us your stories. The next series of videos will address nasal and sinus allergies. Over the years, I've developed stories that I use to teach patients about allergy care so they can better understand their disease and treatment and comply with recommendations.